Welcome back to the deep dive. Today we are really digging into a major new review from European Urology. It's all about the global picture of renal cancer. I mean, this thing is comprehensive. It covers everything: incidence, mortality, genetics, risk factors, the whole nine yards. So our mission, yours and ours, is to kind of cut through all that density. We're aiming to pull out the key facts, the must-knows, almost like a study guide, making it easier to recall what really matters. Okay, let's unpack this.
Yeah, and it's important we're precise. When we say renal cancer RC, we're talking specifically about the malignant growths in the kidney itself. So C64 code, basically. We're excluding tumors in the renal pelvis or things like lymphomas. And this review, it gives us those big global numbers and, critically, the projections, stuff that clinicians and, frankly, policymakers really need to get their heads around.
Definitely. Okay, let's dive straight in then. Section 1, the scale of the problem. Let's start with the baseline. Question 1, what was the actual global burden of RC back in 2022, and where did it rank for men and women?
Okay, so for 2022, the recorded numbers were 434,840 new cases worldwide, and sadly, 155,953 deaths. As for ranking, it's definitely up there. It was the 6th most common new cancer for men and the 9th for women. So, yeah, a significant issue globally.
Those numbers are already pretty stark, but the projections, looking ahead, that's what really jumped out at me from the paper. Nearly 100% jump in deaths. Can you walk us through those 2050 projections?
Right. Those are the figures that really demand attention. But first, the big caveat.
Yeah.
This model is purely based on demographic shifts, so population growth and aging. It assumes the 2022 rates just continue, no improvements factored in.
Okay, so a sort of worst case if we do nothing scenario.
Kind of, yeah. Or maybe if current trends just play out demographically, based on that. By 2050, they project 745,791 new cases. That's a 72% increase. The mortality figure, well, this is projected at 304,861 deaths, a 96% increase, almost double.
Wow, 96%. That's
Yeah. It is. And it's not spread evenly across the globe either. The variation is huge. They estimate, maybe a 19% increase in Europe, but potentially a 106% increase in Africa.
106%. That points to massive disparities.
Absolutely. Which leads us nicely into survival rates, actually.
Right. Question 3 then. How does survival vary globally? Is it as stark as those incidence projections?
It really is. The 5-year overall survival rate for RC has this incredibly wide range globally. We're talking from as low as 40% up to about 75%. So you see places like Oceania hitting around 75%, Europe's maybe 66%, Asia around 69%. But then in Africa, based on the reports they synthesized, they could be anywhere from 40% to 63%. Big difference.
Okay, that ties into my next question, which made me pause when reading the review. It's about the Human Development Index, the HDI. There's a correlation there that feels backwards somehow. Can you explain that? Question 4.
Yeah, this is one of those counterintuitive findings. If you look at the age-standardized rates, the ASRs, which adjust for population age differences, both incidence and mortality, ASRs are actually higher in countries with a higher HDI.
Higher rates in more developed countries? That seems odd. You'd expect better healthcare access to maybe lower mortality or at least catch it earlier?
Exactly. It's puzzling on the surface.
So what's going on? Is it just that they're better at finding it in high HDI countries? More scans, more incidental findings? Or are lifestyle factors in developed nations really driving up the actual rates?
It's almost certainly a mix of both. The correlation definitely highlights differences in infrastructure. Yeah. More CT scans in wealthier nations mean more cancers get detected, including perhaps some that might not have become clinically significant. That's detection bias. But you also can't ignore that many major risk factors, obesity, smoking, high blood pressure, are, well, pretty common in many high HDI countries. So the underlying drivers are there too. It's complex. You have more detection and potentially more underlying risk.
Right. Okay. Fascinating but complicated. Let's shift gears a bit. Zoom in from the global view to the individual. Section 2, genetics. Question 5. How much of RC risk is actually inherited, and when should doctors think about genetic testing?
So the estimates suggest that hereditary factors play a role in about 5 to 8% of all RC cases. It's not the majority, but it's a really important subgroup.
5 to 8%.
Yeah. And the guidelines for when to test are pretty clear, aimed at catching that group. Generally, there are 4 key flags. 1, getting diagnosed young. Usually the threshold is under 46 or sometimes under 50. 2, having tumors in both kidneys or multiple tumors in one kidney, so bilateral or multifocal disease. 3 is family history, having at least one close relative, like a parent, sibling, or child, or maybe even an aunt, uncle, grandparent with RC. And 4, certain specific features under the microscope or other non-kidney signs that suggest a known hereditary syndrome.
Okay, that makes sense. So if someone hits those criteria, testing might be warranted. Now, for question 6, can you give us an example? Name an actionable gene or syndrome, and crucially, what's an associated sign outside the kidney?
The classic example, and probably the most actionable, is von Hippel-Lindau disease,
Hmm.
VHL. It's caused by a fault in the VHL gene. This gene normally helps control cell growth, so when it's broken, you get an increased risk, particularly of clear cell RCC, which is the most common type of kidney cancer. But the key for VHL, and what often flags it, are the extrarenal features. People with VHL can also get tumors in other places, like hemangiomas in the retina of the eye, hemangioblastomas in the brain or spinal cord, and specific adrenal gland tumors called pheochromocytomas.
Ah, so seeing those other issues would be a major clue pointing towards VHL, even beyond the kidney cancer itself.
Exactly. Those extra signs are critical for diagnosis and planning surveillance.
Mhm.
And you can contrast that with, say, hereditary papillary RCC. That's linked to the MET gene. People with that are prone to multiple papillary RCC tumors, but, and this is the key difference, there are currently no known extrarenal signs associated with it, just the kidney tumors. That difference really matters for how you manage and monitor patients.
Got it. Okay, let's pivot now to section 3, risk factors. We know genetics plays a role for some, but what about factors we can't change? Question 7. What are those 5 non-modifiable risk factors that sort of set our baseline?
Right, these are the things we have to factor in but can't alter. They are age risk goes up as you get older. Male sex men are more likely to get RC than women. Geography, as we discussed, where you live matters. Ethnicity or ancestry. And of course, family history, even outside of those specific syndromes. And it's worth mentioning that ethnicity point again. The review highlights that Native and Black African American populations tend to have the highest risk in the U.S. data, while Asian and Native Hawaiian Pacific Islanders have the lowest.
Okay, so age, sex, geography, ethnicity, family history, the fixed baseline. But where's the leverage? Question 8. Which modifiable factors are driving the majority over half of RC cases and deaths?
This is where public health efforts can really make a dent. The big ones are obesity, insulin resistance or type 2 diabetes, high blood pressure, hypertension, having chronic kidney disease already,
Hmm.
smoking tobacco, certain environmental exposures, and lack of physical activity.
Hmm.
Taken together, yeah, these modifiable factors are estimated to be behind more than 50% of the global RC burden.
Let's pick one of those, maybe the trickiest one. Obesity. You said it's a major risk factor, but then there's this obesity paradox. Question 9. What is that exactly and what's the evidence?
Ah, yes, the obesity paradox. It's really quite something. So on one hand, being overweight or obese is absolutely a causal risk factor for developing renal cancer. The data is strong. It might account for up to a third of cases, and the risk ratio can be as high as 1.76 compared to healthy weight individuals. So it clearly increases your chance of getting RC.
Okay, clear link to getting the disease.
Right. And here's the paradox. Once someone is diagnosed with RC, particularly advanced RC, studies suggest that being obese is actually associated with better survival outcomes.
Hmm.
It seems to have a protective effect on mortality, especially for patients getting immunotherapy.
Wow. So it helps cause it, but helps you survive it better. That is counterintuitive.
It is. The biological reasons aren't fully understood yet. Could be related to immune response, metabolic reserves, maybe treatment interactions, but it's a consistent finding that clinicians are grappling with.
Yeah.
How do you counsel patients about weight when it has this dual role?
Yeah, that's a real challenge. Okay, shifting to another modifiable risk, environmental exposures. Question 10. Which specific chemicals or compounds did the review flag as documented risk factors?
The review highlighted several. There's evidence linking increased risk to perfluorinated chemicals, PFAS, the forever chemicals. Also aristolochic acid, which is sometimes found as a contaminant in certain herbal remedies. Then there are industrial solvents like trichloroethylene, TCE, and perchloroethylene, PERC. Even micro or nanoplastic particles are mentioned as an emerging concern. And heavy metals like cadmium,
That's quite a list. Really underscores the environmental health angle.
definitely.
Okay, one more modifiable factor. Smoking. We know it's bad, linked to maybe 19% of cases. Question 11. What about former smokers? If someone quits, does their risk go all the way back down to never smoker levels?
That's a great question. Quitting smoking absolutely reduces the risk compared to continuing to smoke. That's crucial. So cessation is hugely beneficial. However, the evidence reviewed suggests that the risk for former smokers, even long-term quitters, unfortunately remains elevated compared to people who never smoked. It
Yeah.
doesn't seem to completely reset to baseline.
So the damage lingers, even after quitting.
It seems so. which implies that, maybe former smokers could be a group to consider for more targeted surveillance or awareness down the line.
Right. That brings us neatly to Section 4, clinical implications in screening. Given everything we've discussed, the rising numbers, the risk factors, what's the verdict on general population screening? Question 12. Is there good evidence for non-selective RC screening?
The short answer, based on current evidence reviewed here, is no. There isn't strong data to support just screening everybody for renal cancer without considering their individual risk. The potential harms, like finding small, slow-growing tumors that might never have caused problems, leading to unnecessary anxiety tests and treatments, plus the costs seem to outweigh the benefits for the general population right now.
Okay, no mass screening. But you mentioned targeting high-risk groups. That leads to question 13. Can you describe that promising targeted approach used in the Yorkshire Kidney Screening Trial, YKST?
Yes, the YKST is a really interesting example of where things might be heading. It took a pragmatic approach. They focused on a known high-risk group, people who had ever smoked, who were already enrolled in a lung cancer screening program using low-dose CT scans.
Ah, so leveraging existing screening infrastructure.
Exactly. They basically just extended the existing lung CT scan slightly lower to include the kidneys using a non-contrast abdominal CT protocol, so minimal extra hassle or radiation for the participant. And the results were quite compelling. They found one case of confirmed RCC for every 402 people they screened in this high-risk group. Many were found at an earlier stage.
1 in 402 in a high-risk group. That sounds potentially viable.
It suggests that this kind of risk-adapted, targeted screening, maybe piggybacking on other screening programs like lung screening for smokers, could be a feasible and effective way forward. It shifts the conversation from if we should screen to who and how we should screen selectively. And, this raises an important question. Why delve into all this detail, the projections, the genetics, the screening trials? It's because understanding these nuances isn't just academic. It's about figuring out the so what. How do we use this knowledge for smarter prevention? Who needs genetic testing? How do we make policy that actually accounts for these regional differences and risk factors? That's the real value here.
So what does this all mean, tying it together? The big picture is pretty clear, isn't it? We're facing a potentially massive increase in renal cancer globally, largely driven by aging populations. But, critically, a huge chunk of that risk, over half, is tied to things we can potentially change. Obesity, smoking, managing blood pressure, and diabetes. That gives us clear targets for action, for prevention.
Precisely. The modifiable factors are key.
And yet, we have to end on that slightly provocative thought, that complexity around the HDI data. We see higher rates in more developed countries. While lifestyle plays a role, we absolutely have to keep questioning how much of that is true biological difference versus simply better detection and reporting in those areas. It really highlights the need for careful interpretation of global health data, making sure we don't mistake access to healthcare for inherent disease patterns, something to keep scrutinizing for sure.